Welcome to the deep dive. Today we're jumping into something really practical, regional anesthesia.
Yeah, it's a fascinating field.
We've got a whole bunch of insights pulled straight from some top clinical anesthesia textbooks, and our goal really is to give you a clearer picture of nerve blocks, local anesthetics, potential complications, but without drowning in super technical stuff.
Exactly. Think of it like a shortcut through the dense material. We've been digging through chapters on everything from how you actually do the blocks to the drugs themselves, and really importantly, what can go wrong.
Trying to pull out the practical nuggets, the stuff that sticks.
That's the plan. Useful info, hopefully presented in a way that makes sense.
Okay, so let's dive right in then. One of the first things that kind of jumped out was figuring out if the epinephrine you add to local anesthetics is actually doing its job, especially when the patient's under general anesthesia.
Right, because what you look for actually changes depending on which general anesthetic technique you're using. It's not one size fits all.
So under sevoflurane, for instance.
Yeah, with sevoflurane, which is a common inhaled agent, the heart seems more, let's say, directly responsive. So the textbooks highlight a few specific signs.
Like what?
Like a 25% jump in the T-wave amplitude on the ECG, usually looking at lead 2. Or, maybe simpler, a heart rate increase of about 10 beats per minute. Or a systolic blood pressure bump of more than 15 millimeters of mercury.
So multiple potential signs there.
Exactly. It's like the Savola lets those epinephrine signals come through a bit clearer on the monitor.
Okay. But the sources mentioned it's different if you're using TIVA, total intravenous anesthesia.
Precisely. With TIVA, where you're using IV drugs instead of gas, the picture shifts. A change in blood pressure becomes generally a more reliable sign of that epinephrine effect.
Why is that, do you think?
Well, the thinking is that the IV anesthetics themselves affect the heart and blood vessels differently than inhaled agents. They might sort of blunt those direct cardiac responses, the T-wave or heart rate changes, so the blood pressure increase becomes the more obvious clue.
Right, a downstream effect becomes more prominent. That makes sense.
And something that came up again and again in the reading was, slow down, take your time injecting.
Absolutely fundamental. That's a core safety principle in regional. Slow incremental dosing. Always.
Why is that so critical?
It gives you time to watch, to see if you're getting any early signs of the drug going systemic, or worse, going straight into a blood vessel. You can catch it early, react before it becomes a major problem. Pushing a big bolus fast is just riskier.
Got it. Okay, moving on. Stellate ganglion blocks. Maybe first, what exactly is the stellate ganglion?
Sure. It's basically a collection, a cluster of sympathetic nerve fibers down in the neck. Think of it as a junction box for sympathetic signals going to the arm, parts of the head and face, and interestingly, some fibers heading towards the heart too.
And blocking it can be useful for certain pain conditions.
Yeah, things like complex regional pain syndrome, CRPS. That's a common reason. Now, the text highlighted some potential complications, but one thing that was specifically mentioned as not being typical was interesting.
Right. So you can have risks like accidentally hitting the vertebral artery, not good, can cause seizures. Or maybe paralyzing the phrenic nerve temporarily, affecting breathing on that side. Or even getting some spread into the epidural space.
Okay.
But an increase in heart rate, that's generally not what you expect from a stellate ganglion block.
Really? Why not?
Because those sympathetic fibers it carries include the cardiac accelerator fibers, the ones that speed the heart up. So if you block them effectively,
You might actually slow it down a bit.
exactly, you might see a slight decrease in heart rate or no change, but an increase would be unusual for the block itself.
Wow. Okay, that's a key takeaway. Very counterintuitive, perhaps. Now let's get into the nitty-gritty of the drugs. Calculating doses.
Crucial stuff. You absolutely have to know how much local anesthetic and how much epinephrine you're giving.
The sources gave an example, like 60 milliliters of 0.5% bupivacaine with 1 to 200,000 epinephrine. Can we break that down?
Sure. So 0.5% bupivacaine means 5 milligrams per milliliter, simple multiplication. 60 milliliter times 5 milligml gives you 300 milligrams of bupivacaine total.
Okay. And the epinephrine?
A 1 to 200,000 concentration means 1 gram and 200,000 milliliter, which works out nice and neatly to 5 micrograms per milliliter. So again, 60 milliliter times 5 millicgml. That's 300 micrograms of epinephrine.
Getting those calculations right is non-negotiable, obviously.
Absolutely. Patient safety depends on it.
And the texts also gave some maximum recommended doses for different local anesthetics when you add epinephrine for major blocks. These are like guardrails, right?
Exactly. They're based on years of clinical use and help minimize toxicity risk.
Yeah.
For lidocaine and mepivacaine with epi, it's generally around 500 milligrams max. Prelocaine, a bit higher, maybe 600 milligrams.
And bupivacaine.
Bupivacaine is more potent, lasts longer, so the typical max dose with epi is lower, around 225 milligrams. These are guidelines, of course. You always consider the patient, but they're important reference points.
We mentioned epinephrine helps tell us if we're intravascular under anesthesia. But what's its other main job when added to the local anesthetic?
The main reason it's there is vasoconstriction. It clamps down the blood vessels near the injection site.
And that helps how?
2 ways, mainly. First, it keeps the local anesthetic hanging around the nerve longer, so the block lasts longer, doesn't get washed away by blood flow as quickly.
Okay.
Second, by reducing that washout, less local anesthetic gets absorbed into the general circulation over time, which, again, lowers the risk of systemic toxicity. So, longer block, safer profile, it's a win-win.
Makes sense. The texts even mentioned a typical volume for something specific, like a transarterial axillary block.
Yeah, just as a ballpark figure. For that particular approach to the brachial plexus in the armpit, they mentioned typically using around 40 to 45 milliliters of solution. Gives you a sense of the volume needed to bathe those nerves.
Okay, let's shift focus. A complication many folks might have heard of, maybe even experienced after a spinal or epidural. The postural puncture headache, spinal headache.
Ah, yes, PDPH. It's relatively common, unfortunately. The textbooks say the typical onset is usually between 12 and 72 hours after the dural puncture.
But not always.
Not always. It can happen almost right away in some cases, or much less often, be delayed even longer. But that 72-hour window is the classic time frame.
And the key feature is that postural thing, right? How it changes when you sit up or lie down.
You got it. That's the hallmark.
Yeah.
The headache gets significantly worse when the patient is upright sitting or standing, and gets much better, often goes away completely when they lie flat. Supine relief.
And the pain itself, where is it usually felt?
Typically described as frontal, so forehead area, or occipital, back of the head, or sometimes both.
But it's not always just a headache, is it? There can be other symptoms too.
Absolutely. Patients might feel nauseous, maybe even vomit. Loss of appetite is common, and visual stuff can happen. Blurred vision, seeing double, being really sensitive to light.
Anything else?
Yeah, interestingly, hearing can be affected too. Things like ringing in the ears, tinnitus, or even a noticeable decrease in hearing. So it could be a whole constellation of symptoms, not just the head pain.
Okay, let's talk about a different block now, the transversus abdominis plane block, the TAP block. What's the main goal here?
The primary aim of a TAP block is pain relief for the abdominal wall, so skin and muscles of the abdomen. It's really useful after surgeries with abdominal incisions like C-sections or hernia repairs, that sort of thing.
And which nerves are we actually trying to hit to get that effect?
We're targeting the nerves that run in that plane, specifically the subcostal nerve, which is T12, and then the ilioinguinal and iliohypogastric nerves, which both come from L1. Blocking them in the TAP-P provides pretty good analgesia for the front and side of the abdominal wall.
And doing the block often involves ultrasound now, right? For precision.
Oh, yeah. Ultrasound has really transformed TAP-P blocks. It lets you see the muscle layers, clearly the external oblique, internal oblique, and the transversus abdominis muscle underneath.
And then the target is?
The target is the fascial plane between the internal oblique and the transversus abdominis. That's the space where those nerves travel. So you guide the needle there using the ultrasound and inject the local anesthetic into that plane.
Not into the muscle itself.
Right. You want it to spread along that plane to cover the nerves. Injecting into the muscle belly isn't as effective.
And volume-wise, what's typical for a TAP block?
Usually something like 20 to 30 milliliters of local anesthetic solution per side. For example, they mentioned using bupivacaine, maybe dosed around 2 milligrams per kilogram body weight, split between the two sides. That volume helps ensure adequate spread.
Okay, moving down the body now. Ankle blocks. Which nerves are involved there?
For a standard ankle block, you're typically aiming for 5 nerves that provide sensation to the foot.
5, okay.
Yep. You've got the saphenous, the superficial peroneal, the sural, the posterior tibial, and the deep peroneal.
And I read something about nerve stimulation being different for some of these.
That's right. The saphenous, superficial peroneal, and sural nerves are purely sensory below the ankle. So if you try to stimulate them with a nerve stimulator, you won't get a muscle twitch in the foot. They just carry feeling.
So if you are using a nerve stimulator for an ankle block, Which nerves are you looking for a motor response from?
Mainly the posterior tibial nerve. That's a key one. Stimulating it should cause the toes to curl down plantar flexion and maybe the foot to turn inward inversion. It covers most of the sole.
And the other one.
The deep peroneal nerve. Stimulating that one typically causes the foot and toes to lift up dorsiflexion and maybe turn outwards. Version. It covers that little web space between the big toe and the second toe.
The sources mentioned it can be tricky to stimulate the posterior tibial nerve in some patients.
Yes, particularly in patients with diabetic neuropathy. The nerve damage from diabetes can make it much harder to get a good, reliable motor response.
So what do people do then?
Well, sometimes, especially if stimulation is difficult, or for the purely sensory nerves, clinicians will just use an infiltration technique. Basically injecting the local anesthetic based on anatomical landmarks where they expect the nerve to be, without relying on stimulation. That's also a common approach.
Shows the flexibility needed sometimes. Okay, let's pop back up the limb to the axillary block. Also uses nerve stimulation sometimes.
Definitely. For an axillary block, when using nerve stimulation, the goal is to get that desired muscle twitch at a really low current, usually 0.5 milliamps or even less.
And why such a low current?
A response at that low level suggests your needle tip is really close to the nerve, which means you're more likely to get a solid block, potentially with less local anesthetic volume.
And what are the specific twitches we're looking for with the different nerves in the axilla? There are several packed in there.
Right. So if you stimulate the musculocutaneous nerve, which often branches off a bit higher, you should see elbow flexion, bending the elbow. Stimulate the radial nerve, and you're looking for extension straightening of the fingers, wrist, maybe the elbow, and supination, turning the palm up.
Ulnar nerve.
Ulnar nerve stimulation gives you wrist flexion, bending the wrist down, plus flexion of the little finger and ring finger, and thumb adduction, pulling the thumb in towards the palm.
And the last one, the median nerve.
Median nerve stimulation causes wrist flexion, flexion of the index and middle fingers, thumb opposition, touching thumb to fingertips, and pronation, turning the palm down. Knowing these specific responses is really key to confirming you're in the right spot for each nerve.
Super helpful detail. Okay, let's shift to some neurological signs. The text made a distinction between nerve root impingement and something called Lermidl sign.
Yeah, this is important for diagnosis when someone has arm symptoms. Let's say a patient gets numbness or tingling paresthesia down one arm, but only when they tilt their head and neck backwards into extension. That pattern strongly suggests a possible nerve root impingement in the neck, like maybe the C6 nerve root is getting pinched when they extend, causing symptoms in the thumb area, for example. The movement narrows the space where the nerve exits the spine.
Right. And how is the Lermidl sign different?
The Lermidl sign is completely different. It's this sudden electric shock-like feeling that shoots down the person's back, sometimes into their legs, specifically when they flex their head forward, ducking their chin to their chest.
Triggered by flexion, not extension.
Exactly. And it points towards a problem in the posterior columns of the spinal cord itself. The pathways carrying sensation-like position sense, not a peripheral nerve root issue. So flexion causing that shock-like sensation, think spinal cord pathology, not just a pinched nerve in the neck.
Okay, clear distinction. Neck extension points to root, neck flexion with shock points to cord. Got it. Now, interscalene blocks common for shoulder surgery. There's a side effect mentioned as being almost guaranteed.
Yes. Ipsilateral phrenic nerve paralysis, meaning the diaphragm muscle on the same side as the block gets temporarily paralyzed.
And that happens how often?
With a successful, effective interscalene block, pretty much 100% of the time. It's almost unavoidable because the phrenic nerve runs right near the brachial plexus in that area.
Wow, 100%. Does that usually cause breathing problems?
In most healthy people with good lung function, often not symptomatically, the other side of the diaphragm still works fine. But, and this is a big but, you absolutely have to consider it, especially in patients with pre-existing breathing issues, COPD, severe asthma, morbid obesity. In those folks, losing half their diaphragm function, even temporarily, could be a significant problem.
And the texts had a practical tip. If you actually stimulate the phrenic nerve while placing the block.
Right. If you get a diaphragm twitch or the patient hiccups, it means your needle is probably too far forward, too anterior.
So you should
redirect. Aim the needle a bit more posteriorly towards the back to get closer to the brachial plexus and hopefully minimize direct phrenic nerve involvement, even though some block is still likely.
Good practical advice. Okay, let's talk about some of those immediate acute complications that can happen during or right after a block. The sources compared a few things. Intravascular injection, Bizel-Gerish reflex, stellate ganglion block effects, and intravesical injection. Can we differentiate those?
Let's try it. First,
Yeah.
intravascular injection. If you accidentally inject a load of local anesthetic right into a vein or artery,
Bad news.
very bad. It goes straight to the brain and heart in high concentration. So the first signs are usually CNS toxicity, dizziness, ringing ears, metallic taste, maybe confusion, and then potentially seizures.
Okay. What about the Bizel-Gerish reflex?
This one is different. It's seen more in awake patients, often sitting up maybe during shoulder surgery with an interscaling block. It's characterized by a sudden dramatic drop in blood pressure, hypotension, and a significant slowing of the heart rate bradycardia.
Why does that happen?
The theory involves receptors in the heart. When the patient is sitting up, maybe less blood returns to the heart, stimulating these receptors, which triggers a reflex causing profound vasodilation and bradycardia. Importantly, their breathing is usually normal during this.
So, circulatory collapse, but not respiratory.
Generally, yes. Now, contrast that with a stellate ganglion block effect. As we said earlier, a successful stellate block usually causes Horner syndrome on that side.
The droopy eyelid, small pupil.
Right. Ptosis, meiosis, and maybe less sweating on that side of the face. Anhidrosis. But crucially, no breathing problems are typically associated with just a stellate block.
And finally, the really scary one, intrathecal injection.
Yeah, injecting into the spinal fluid, even a small amount of local anesthetic meant for a peripheral block can cause a total spinal block if it gets in there.
Which means?
Profound hypotension, severe bradycardia, complete respiratory muscle paralysis leading to apnea, stop breathing, and likely cyanosis turning blue. A catastrophic event requiring immediate aggressive resuscitation. Highlights why careful technique is paramount.
Absolutely critical distinctions. Okay, let's look at the drugs again. The idea of chiral local anesthetics came up. What does that mean?
Okay, so some local anesthetics like mepivacaine, bupivacaine, ropivacaine, levobupivacaines, they're what we call chiral molecules. Think about it like your hands. Your left and right hands are mirror images, but you can't perfectly superimpose them.
Okay, like mirror image molecules.
Exactly. These non-superimposable mirror image forms are called enantiomers. Mepivacaine and bupivacaine are usually sold as racemic mixtures, a 50-50 mix of the left-handed form and the right-handed form.
And why does this matter clinically?
Because the different handedness, the different enantiomers can interact with the body differently. Studies have shown that the pure S forms like ropivacaine and levobupivacaine generally seem to have less potential for neurotoxicity, and especially heart toxicity, cardiotoxicity, compared to the racemic mixtures like bupivacaine.
So potentially safer.
Potentially safer, yes, especially maybe with larger doses or continuous infusions where toxicity is a bigger concern.
Is there a downside?
Well, some clinical experience suggests the pure S forms might be slightly less potent or maybe have a slightly shorter duration of action compared to the standard racemic versions. So maybe a slight trade-off. Oh, and lidocaine, it's acral. Doesn't have this left-right-handedness thing.
Interesting. So choosing between, say, bupivacaine and levobupivacaine might involve weighing that potential safety benefit against maybe a slightly less intense block.
That's often the consideration, yeah.
Okay, zooming out again. Anatomy time. The nerves of the lower extremity, where do they all come from?
It's a complex network. It starts on the lumbar and sacral spinal nerve roots, specifically L1 down to S4.
Okay.
The upper roots, L1 to L4 roughly, form the lumbar plexus. This gives rise to nerves like the genitofemoral, the lateral femoral cutaneous, that's the one involved in neuralgia paresthetica, sometimes the obturator nerve, and the big one, the femoral nerve.
And the sciatic nerve, the really big one.
The sciatic nerve is huge. It actually gets contributions from both the lumbar plexus, L4, and the sacral plexus, L4 down to S3. It then runs down the back of the thigh.
And branches out.
Yeah, it eventually splits into the common peroneal nerve, which then divides further into superficial and deep branches, and the tibial nerve. The sural nerve, which runs down the calf, is actually formed by branches from both the tibial and common peroneal nerves. Knowing this map is fundamental for lower limb blocks.
Absolutely. What about nerve injuries related to anesthesia, specifically to the brachial plexus in the arm? Are those common?
Thankfully, significant brachial plexus injuries directly caused by anesthetic blocks are pretty rare. But when they do happen, we don't always fully understand exactly why.
So prevention is key. How?
The main principle is just minimizing trauma, being gentle, avoiding forceful injection, not injecting if the patient reports severe pain. Careful technique.
Does ultrasound help prevent injury?
Logically, it should. Seeing the needle in the nerve seems like it would reduce the risk of hitting the nerve directly. And while there's a strong theoretical basis for it, and it definitely helps with block success, The hard evidence, the big clinical trials definitively proving that ultrasound significantly reduces nerve injury rates compared to, say, nerve stimulation alone. That evidence is still a bit limited or evolving.
So careful technique remains paramount, regardless of the guidance method.
Absolutely. Meticulous technique is always key.
Okay, let's tackle a really serious emergency. Local anesthetic systemic toxicity, or AST. The cardiovascular effects seem particularly dangerous.
They are. While AST often starts with CNS symptoms, like we discussed earlier, dizziness, seizures, it's the effects on the heart that are often fatal. It can cause electrical problems like heart block or arrhythmias. It can weaken the heart muscle contraction, myocardial depression, and it can lead ultimately to cardiac arrest.
If that happens, cardiovascular collapse due to AST, what's the immediate plan?
First things first. Recognize it, call for help immediately, and then aggressive airway management and full cardiovascular support following standard ACLS protocols. But there are some important modifications for LAST-WUTS.
Like what? Which drugs should be avoided?
Crucially, in LAST-induced cardiac arrest, you should avoid vasopressin. Also avoid calcium channel blockers and beta blockers. And definitely don't give any more local anesthetics.
What about epinephrine if needed for resuscitation?
If you need epinephrine, the doses should be reduced. Think smaller doses, like less than 1 microgram per kilogram, compared to standard ACLS.
Okay.
The heart is already sensitized and irritable from the local anesthetic.
And then there's the specific antidote, lipid emulsion therapy.
Yes. Intralipid, usually to 20% emulsion. This is vital. The protocol generally starts with an initial bolus. 1.5 milliliters per kilogram of lean body weight, given quickly, over about a minute. Followed immediately by a continuous infusion at 0.25 milliliters per kilogram per minute.
What if the patient's still unstable?
If cardiovascular collapse persists, you can repeat the bolus maybe once or twice, and you can double the infusion rate to 0.5 milliliters per kilogram per minute.
How long do you continue the infusion?
You should continue it for at least 10 minutes after the patient becomes hemodynamically stable.
Yeah.
There's also a rough upper limit for the total dose, around 10 millimolars per kilogram over the first 30 minutes.
And if even lipids don't work?
If you've done everything, airway, CPR, appropriate drugs, lipid emulsion, and there's still no response, you have to strongly consider cardiopulmonary bypass, if it's available. You can buy time for the local anesthetic to clear.
The sources specifically warned against using propofol here, even though it's a lipid. Why not?
Good question. Propofol is in a lipid emulsion, so theoretically it could bind some local anesthetic. But
Sure.
propofol itself is a significant cardiac depressant.
Ah.
So giving it in this situation would likely worsen the cardiovascular collapse. The negative effects far outweigh any tiny potential benefit from the lipid content. So definitely avoid propofol for treating LS.
Critical point. Okay, let's circle back to the interscalene block technique. Needle insertion specifics.
Okay, the common landmark approach starts by finding the interscalene groove that dip between the anterior and middle scalene muscles in the neck. You usually find it around the level of the cricoid cartilage, which corresponds to about C6.
And the needle direction.
Typically, insert the needle perpendicular to the skin initially, then aim it slightly medially inward, caudally down towards the feet, and a little bit posteriorly towards the back.
Why that specific direction, especially aiming downwards, caudally?
That caudal angulation is really important for safety. It helps steer the needle away from the vertebral artery, which runs nearby. Injecting into the vertebral artery is disastrous. Sends local anesthetics straight to the brainstem, causing immediate seizures.
Okay, vital safety step.
It also helps reduce the risk of accidentally entering the epidural or spinal space.
We already talked about the almost certain phrenic nerve block. Any other nerves nearby that can get caught up in an interscalene block?
Besides the phrenic nerve, yeah. Occasionally, the recurrent laryngeal nerve can get blocked. That's the nerve controlling most vocal cord muscles.
Is that usually a problem?
Usually not, if it's just one side. The patient might sound hoarse for a bit. But if they happen to have a pre-existing problem with the other vocal cord, blocking the second one could potentially cause airway obstruction. Very rare, but something to consider. The vagus nerve can also be affected sometimes, but it's usually not clinically significant.
Okay, let's talk about rare but serious complications after spinal or epidural procedures. Epidural hematomas. How rare are we talking?
They are pretty rare. The estimates are roughly 1 in 220,000 for spinals, maybe 1 in 150,000 for epidurals in patients not on anticoagulants.
But anticoagulants change the picture.
Dramatically.
Yeah.
Especially low molecular weight heparin, LMWH. If a patient is getting LMWH, the risk jumps significantly. Maybe up to 1 in 40,000 for spinals, and even as high as 1 in 3,000 for patients with epidural catheters left in place while on LMWH. much, much higher risk.
What are the warning signs of an epidural hematoma forming?
The classic symptoms are severe back pain, often shooting down the legs, radicular pain, new or worsening bowel or bladder problems like incontinence or retention, and progressive weakness or numbness in the legs. These are red flags.
How do you confirm it, and what's the treatment?
Diagnosis is typically made with an urgent MRI scan, and treatment needs to be fast, prompt surgical decompression, usually a laminectomy, ideally within about 8 hours of symptoms starting, to give the best chance of preventing permanent neurological damage.
How does that differ from, say, an epidural abscess?
An epidural abscess is an infection, not just bleeding. It usually develops more slowly, over days perhaps, and is often associated with fever and other signs of infection, whereas a hematoma is typically more sudden onset after the procedure.
Okay. To understand how these blocks work, it helps to know about different nerve fiber types. Can you give us a quick overview?
Sure. Nerves aren't all the same. We classify the fibers based on things like their size, diameter, whether they have a myelin sheath, insulation, how fast they conduct signals, and what job they do, motor, sensory, autonomic.
So the main categories.
The myelinated ones are generally type A and type B. Type A are further broken down by size, fastest first.
Wow.
A alpha, a beta, A gamma, AO, and A delta, A.
What do they do?
A alpha fibers are the big motor neurons going to skeletal muscles. A beta carry touch, pressure, position sense. A gamma are involved in muscle tone. And A delta carry sharp pain, temperature, and some touch.
And type B.
Type B fibers are smaller, myelinated fibers. They're mainly preganglionic sympathetic fibers, part of the autonomic nervous system controlling involuntary function.
And the unmyelinated ones.
Those are the type C fibers, smallest diameter, slowest conduction. They include the postganglionic sympathetic fibers and also the sensory fibers that carry dull, aching, poorly localized pain, temperature, and crude touch.
Does this difference in fibers matter for local anesthetics?
It does. Local anesthetics tend to block the smaller, more active fibers more easily. So you often lose pain and temperature sensation carried by A delta and C fibers before you lose touch, A beta, or motor function, A alpha. This differential blockade is partly explained by these fiber characteristics.
Interesting. Okay, let's shift to a complication seen with long-term intrathecal catheters used for chronic pain granulomas.
Right. This isn't about acute overdose, but rather an inflammatory mass, a granuloma, that can form right at the tip of the catheter inside the spinal fluid space.
What causes them?
It seems to be associated more with higher concentrations and higher daily doses of certain opioids, particularly morphine or hydromorphone. The texts mention doses often over 10 milligrams per day, and also with longer duration of therapy, typically more than 6 months.
How would a patient know if they might be developing one? What are the symptoms?
They might notice their pain medication isn't working as well as it used to, or they could develop new pain, maybe tingling or numbness in a new area, or even new weakness or bowel bladder changes.
So loss of effect or new neurological symptoms.
Exactly. Because of this risk, patients with intrathecal pumps need regular monitoring. If a granuloma is suspected based on symptoms, they need imaging, usually an MRI, and likely a neurosurgical consultation to figure out the best management.
Good to know. Back to basics. Topical anesthetics. We know benzocaine, but what others are used topically?
Besides benzocaine, things like tetracaine, cocaine, yes, actual cocaine, used medically sometimes for intense vasoconstriction and anesthesia in nasal surgery, for instance, and lidocaine, can all be formulated for topical use on skin or mucous membranes.
And how are these broken down? We mentioned esters earlier.
Right. The ester-type local anesthetics that includes benzocaine, procaine, chloroprocaine, tetracaine, they get metabolized mainly by an enzyme in the blood plasma called pseudocholinesterase.
The same enzyme that breaks down succinylcholine?
Exactly the same one, which has implications if someone has a deficiency in that enzyme.
Benzocaine also had some unique properties mentioned.
Yeah, 2 key things. First, benzocaine, along with another local called prelocaine, carries a risk of causing methemoglobinemia, where the iron in hemoglobin gets changed and can't carry oxygen well. Second, benzocaine has a really low pK, around 3.5.
And why does pK matter?
The pK tells you about the balance between the charged, ionized, and uncharged, unionized forms of the drug at body pH. Because benzocaine's pK is so low, at normal body pH, around 7.4, almost all of it is in the uncharged form. Most other locals have higher pK, so they exist as a mix of charged and uncharged forms.
Okay, and bringing it all together, how do local anesthetics actually stop nerve signals, the basic mechanism?
It's a 2-step process, essentially.
Right.
The unionized, uncharged form is lipid-soluble, so it can diffuse across the nerve cell membrane.
Gets inside the nerve cell.
Right. Once inside, where the pH might be slightly different, some of it becomes ionized, charged again, and it's this ionized form that physically plugs up the voltage-gated sodium channels from the inside.
Those channels are needed for the nerve impulse.
Absolutely. They're what lets sodium rush into the nerve to create the electrical signal, the action potential. If they're blocked, no signal can travel down the nerve. You need to block enough channels along a certain length of the nerve, typically covering about 3 of those gaps in the myelin, called nodes of Ranvier, to effectively stop conduction.
And myelin helps?
Myelin actually helps concentrate the drug effect at those nodes. Also, nerves that are firing more rapidly tend to get blocked more easily, a phenomenon called use dependence.
Fascinating. Okay, let's revisit postural puncture headaches one last time. We covered onset, symptoms. What about risk factors and treatment again?
Sure. We said onset usually 12-48 hours. Postural headache, maybe nausea, visual changes, hearing issues. The underlying cause is thought to be CSS leaking out through the dural hole, lowering intracranial pressure.
And who's more at risk?
Risk factors include pregnancy, using bigger needles, using cutting tip needles instead of pencil point ones, having multiple puncture attempts, and being younger. Young adults seem more prone than kids or older folks.
Initial treatment is conservative.
Yeah, start with bed rest, fluids, oral or IV, simple pain meds. Some people try caffeine too.
And if that doesn't cut it?
If the headache is severe and persists after 24-48 hours to the conservative therapy, the go-to treatment is usually an epidural blood patch.
Injecting the patient's own blood.
Exactly. You take about 10-20 milliliters of the patient's blood and carefully inject it into the epidural space near the puncture site. It forms a clot, plugs the leak, and often provides pretty dramatic, rapid relief. Highly effective for persistent PDPH.
Okay. The sources also briefly mention some other interventional procedures for back pain beyond typical regional blocks.
Right. These are more specialized pain management techniques. Things like ID intradiscal electrothermal therapy, where they heat the inside of a disc to try and treat disc-related pain, or percutaneous disc decompression, sometimes called nucleoplasty, using radiofrequency to remove a bit of disc material.
What?
Spinal cord stimulation is a big one. Implanting electrodes near the spinal cord to modulate pain signals usually involves a trial first, then permanent implant if it helps. And vertebroplasty, injecting bone cement into fractured vertebrae, often for osteoporosis-related compression fractures.
And for managing chronic neuropathic pain, nerve pain pharmacologically. Lots of options there too.
Oh yeah, it's often multimodal. You might use standard analgesics like NSAIDs or opioids, but often need drugs specifically targeting nerve pain mechanisms.
Like what classes of drugs?
Antiepileptics, both older ones and newer ones like gabapentin or pregabalin. Antidepressants, especially tricyclic antidepressants and SNRIs like duloxetine. Topical agents like lidocaine patches or capsaicin, even some antiarrhythmics like mexiltine, which is like an oral form of lidocaine.
Can you give a quick mechanism for a couple of those, like duloxetine or gabapentin?
Sure. Duloxetine is an SNRI, so it boosts serotonin and norepinephrine levels, which helps modulate pain pathways descending from the brain. Gabapentin seems to work by binding to calcium channels on nerve endings, reducing the release of chemicals that transmit pain signals. Carbamazepine, an older anticonvulsant, is particularly good for trigeminal neuralgia, though its exact pain mechanism isn't fully clear. Mexiltine probably works by stabilizing nerve membranes, similar to lidocaine.
Lots of different approaches needed for nerve pain. Okay, almost wrapping up. The texts give a nice summary of nerve supply for some key body functions.
Yeah, it connects the anatomy to physiology. For example, breathing. Normal breathing and coughing mostly rely on the diaphragm, innervated by the phrenic nerve from C3, C4, C5, C3, 4, 5 keeps the diaphragm alive, right?
Right. Heart rate.
Heart rate is set by the SA node, but modulated by sympathetic speeding it up from T1, T4 spinal segments, and parasympathetic slowing it down via the vagus nerve, cranial nerve X.
Labor pain. That had specific pathways mentioned.
Yep. First stage labor pain contractions, cervix dilating, that's mainly T10 to L1 nerve roots. Second stage adds pain from the birth canal stretching, which involves those same T10-L1 nerves, plus the pudendal nerve from S2, S4.
And the gut. Sympathetic control.
Sympathetic nerves to the gut travel through the celiac plexus, originating from spinal segments T5 down to T12 via splanchnic nerves. Generally, sympathetic stimulation inhibits gut motility and secretions.
Really shows how targeted blocks can affect specific functions. Okay, last major topic. Awake intubation and numbing the airway.
Crucial skill sometimes. You need to anesthetize the airway mucosa using topical or injected local anesthetics to make it tolerable for the patient.
And the sensory innervation comes from which main nerves?
3 key cranial nerves,
Yeah.
Trigeminal V, glossopharyngeal IX, and vagus X.
Can we map that out quickly? Trigeminal?
Trigeminal nerve branches cover the nasal cavity and the roof and floor of the mouth, hard and soft palate.
Glossopharyngeal.
Glossopharyngeal, IX, gets the back third of the tongue, the vallecula, base of tongue glottis area, the walls of the pharynx, and the tonsils.
And vagus. That seems key for the larynx itself.
Very key. The vagus X gives off the superior laryngeal nerve and the recurrent laryngeal nerve. The internal branch of the superior laryngeal provides sensation above the vocal cords. The recurrent laryngeal nerve provides sensation below the vocal cords.
What about motor supply to the larynx?
Also mostly vagus. The recurrent laryngeal nerve supplies all the intrinsic laryngeal muscles except the cricothyroid. The cricothyroid muscle is supplied by the external branch of the superior laryngeal nerve, also from the vagus. And the muscles of the pharynx itself get motor input from the pharyngeal plexus, which includes fibers from the accessory nerve. Knowing this detailed map lets you effectively numb the airway for an awake look.
That's an incredibly detailed map, essential for that procedure.
Wow, we have covered a ton of ground today in this deep dive. We really have.
Yeah.
From spotting epinephrine effects under different anesthetics to that weird heart rate thing with stellate blocks, dose calculations, spinal headaches, TB blocks, elast management, all the way to nerve fiber types and airway anatomy.
It's quite the journey
Right.
through regional anesthesia concepts. You know, the thing that really stands out to me is the nuance. Even something seemingly simple like, does the epi work? Depends entirely on the context.
Absolutely. It really reinforces that this isn't just cookbook medicine. There's so much underlying physiology and pharmacology to consider for safe and effective practice. Every detail matters.
So for everyone listening, here's a final thought to chew on. We talked about different nerve fiber types, A, alpha, C fibers, etc., and how they respond differently to local anesthetics. Thinking about that, how might future drug delivery systems become even more targeted? Could we one day selectively block only the pain fibers, leaving motor function completely intact with even fewer side effects?
That's the million-dollar question, isn't it?
Yeah.
The potential for more targeted therapies is huge. It highlights how understanding these fundamentals can drive innovation.
Definitely something to think about. The practical implications of everything we discussed today are vast, touching so many areas of medicine.
We really hope listeners can take these concepts and think about how they apply in their own clinical worlds, whatever that might be.
Well, thanks so much for joining us on this deep dive. Hope you found it useful. Until next time, take care.